All right, there we go. And so patient-centered care, cancer pathology, how diagnosis drives treatment. That's with Yuri Fedoriw, MD. And I apologize, the slides are moving a little sluggishly. There's a full bio there, certainly welcome to read that, but I'm going to jump in with our David Letterman style. We'll do top five. So first, he has been a proud member of the UNC cancer community and the Lineberger Comprehensive Cancer Center since 2008. So that these are our top five for Dr. Fedoriw. And four, passionate about providing optimal diagnosis for cancer care. Three, he directed the division of hemapathology from 2012 to 2019 before starting a research lab and taking over as co-director of the Malawi Cancer Program. And number two, he enjoys interacting with clinical teams, trainees, staff, and medical students. And our number one, married to a UNC family medicine physician, which adds an important primary care perspective to cancer diagnosis. Dr. Fedoriw, welcome. We're so glad to have you here today.
Thank you. And I hope everyone can hear me okay. Tim, is that fine with the...
Yeah, that's loud and clear. Yeah, and that's great. My wife is a nurse within Foronk at the cancer hospital. So I certainly, we have a lot of good opportunities to reflect on
I learned
things
most
related.
things that I do in medicine from her, from her in general. So, all right, so we can go ahead and get started here. So we'll start up with an easy one, and then we'll move into the talk and objectives. But effective cancer care requires accurate pathologic diagnosis.
Boy, that sounds awfully relevant. And these are usually kind of a softball for this first one. While folks are thinking about that, I'll flash up our disclosure screen. Folks don't have to read that, but we do need to put that up. All right, and let's see how they're doing, and give them 15 seconds or so to go ahead and respond to this.
I want to give them too much time because if someone answers false, it'll be problematic. All right, so thank you so much for joining. And right, so that is the topic that we'll be discussing today, is the role of pathology, and more importantly, how it is that diagnoses for cancer are made. And it largely reflects a lot, which I'll bring up in the talk, but largely reflects a lot about our understanding of cancer biology and the research that's been going on for decades, and how that is folded into cancer care on a daily basis. So we will kind of review some of that. Again, my name is Yuri. In the objectives of this talk, as we'll describe the evolution of testing methods for cancer diagnosis, all of you will see the parallels to how the pathology and diagnostics parallels clinical medicine in many ways, and I'll explain that concept. Recognize how classification systems are developed and then used to uniformly diagnose tumors. So it seems very straightforward when you think about a way of making a diagnosis. But we all need to be speaking the same language. So whatever we're being diagnosed in any corner of this state or the country, or hopefully the world, we can all get treated appropriately. As I've learned, the art of our clinical colleagues' cancer care, of your cancer care, often isn't necessarily from choosing the right therapy. It is from managing all of the issues of the patient, which are far more complicated than the biological ones that we tend to deal with. So in pathology, we're using all of the data to get a diagnosis that can be made here and at Duke and in a different state, different part of the country. But in general, that is what decides the baseline treatment. And then your ability and the clinical team's ability to manage all of the issues surrounding the patient are far greater than the ones that we face. So we'll recognize how we select appropriate tissue for diagnosis. And again, that'll impact when reports can be issued on patients. and describe the development of these, what many of you know as synoptic reporting for cancer diagnoses developed by the CAP, or College of American Pathologists. So briefly, what we are getting to is trying to make a diagnosis of cancer from tissue. And so on the left, we see normal lung tissue. These are the open alveoli that allow for the exchange of oxygen. And on the right, you have a infiltrate of cells that we recognize as cancer. And so this is the relationship to clinical medicine, is that you have to know normal to then walk into a room in many of your cases and identify abnormal. We have to know normal in pathology to then walk into our cases or walk to our microscope in this case and identify these cells as being abnormal and cancerous and malignant. And it's very, very similar. So the more practice you have, as you well know, the better you are at identifying the issues at hand. And so how we get from this normal lung to lung cancer diagnosis is what we will talk about today. So while most of the time, I think pathology is very much seen as a field of a microscope, right? That you use a microscope to make a tissue diagnosis. The technology that has allowed us to do that has been around for hundreds and hundreds of years. And the only thing that changes is the quality of the lenses, right? But the technology itself hasn't changed significantly over the past decade, over the past 50 years, 100 years even. And so it's not unlike a refrigerator, right? So refrigerators keep food cold. They kept food cold 50 years ago, and they'll keep food cold now. But now you could, get a nap on your phone and connect to your refrigerator and do these things that you couldn't do with the refrigerators of the past. But the bottom line is that there's still the ability to make a diagnosis from light microscopy has existed in its current form for many decades. So this is a schematic on the left, this is a schematic of the light microscope. On the right is a setup in a current pathology practice. This was in my office. Here's a microscope on the right. It's connected to a computer where we enter the information into the medical record. We can share things on a screen like we have up here, and you could show images to clinical teams as well. And we do this all the time. In most areas of pathology. I practice hematopathology, mostly the blood cancer diagnosis is the focus of my clinical work and research. So this is the first of your questions here. So when a patient has a breast lumpectomy, when are the first slides ready to review by a pathologist? All right. So this is wonderful. Yeah, exactly. Yeah. So this is great. It's a very difficult question and explains a lot about, I think, misunderstandings about what does that mean to have slides reviewed. So and we'll go through that in a moment. The answer is actually after 1 to 2 days that the slides or the histologic slides are ready, and I'll explain that process. There are many different forms of identifying tissue. So are looking at tissue. One can do an intraoperative evaluation, or what's called a frozen section diagnosis, to evaluate for, let's say, margins of a tumor, to see whether the tumor is expanding, or to see whether tissue is present in the biopsy material so that it can be looked at later under true histology. But it does take a few days for the first slides to come out. And then even longer for other stains to be done and other testing to be done on that tissue, which again we'll go through momentarily. Oftentimes, it all depends on the complexity of the case as to how long the report takes to generate. But typically speaking, we get the cases both in surgical pathology and hematopathology come out after a few days of interpretation and processing. So this is the process that is quite nebulous to most, including me even during residency, as to how tissue gets evaluated, our tissue gets prepared for evaluation by a pathologist. So a small biopsy, let's say a lymph node, gets cut by a histology tech, or resident, who then puts pieces of that tissue into what we call a cassette, into this little plastic cassette that the top closes. This tissue gets then fixed in formalin that preserves a lot of the morphology and histology and the architecture so that we could ultimately look at that tissue under the microscope. And that cassette with the fixed tissue gets placed on a tissue processor, which typically processes overnight. And in that process, the tissue is progressively dehydrated with increasing concentrations of alcohol, to a point at which we can then prepare the tissue further for slide development. A histology technician or technologist rather removes the tissue from the cassette, places it underneath in this little metal container, this mold, and pours wax. This is the pouring wax onto the top of that. And that paraffin hardens ultimately. And then when you flip it over, you get this look to the cassette. So here's the cassette that you see first. This is the wax. And then this is the tissue or lymph node in this case that was embedded within that wax. It is then mounted onto this microtome that sections very thin slices of that tissue that is mounted onto glass slides. The wax is melted off, and it is stained by what we call the conventional H&E stain or histology stain, H&E standing for hematoxylin and eosin. The eosin is the blue, and the hematoxylin is the pink, and I'll show you how that is used in a moment. The blue part of it, the eosin part of it, stains where the nuclei are. And again, when we see lots of blue, that means there are a lot of nuclei, a lot of condensed cells, packed together cells, often indicative of malignancy. So this is, just like I said at the beginning with a normal versus abnormal, this is what normal cervical epithelium looks like. So after seeing enough of them, we see that there is this really darkly nucleated cell line here in the middle. These cells mature to give rise to all of these cells here on top, right? So the cells mature from here to here. And it's all pattern recognition, like a lot of what clinical medicine is recognizing a certain presentation as a certain look to a patient, a certain look to a malignancy, and then managing that. And that's exactly what is done here. This is normal cervical epithelium. In contrast, this is cervical epithelium that has undergone neoplastic change related to HPV infection. So instead of seeing an organized mucosa, rather an organized epithelium with a dark basal layer here, you see the same types of cells extending all the way up to the surface. This is the change that we see associated with HPV-related dysplasia of cervical mucosa. And to make it even kind of easier, because it sometimes is this dramatic, we sometimes see that change very clear, even from this low power look of the normal epithelium on the left, a very clear demarcation to the neoplastic or dysplastic epithelium, abnormal growth that we see on the right. And so this is the basis of all of the pathologic diagnosis that we still make now, are still based on our ability to differentiate normal from abnormal and then select appropriate testing. It's like in clinical medicine, you have an impression of what your patient has, and then the testing follows your expectation of what the diagnosis and either confirms or refutes your previous expectation of what the diagnosis may be. Cytology, that is, or cytopathology, the evaluation of individual cells, is also very common, certainly in the setting of cervical dysplasia and cervical cancer. And so there are differences in how it looks cytologically as well. These are benign squamous, superficial squamous epithelial cells. And again, these are the dysplastic epithelial cells with very large dark nuclei that we have come to recognize as being the either malignant or pre-invasive component of this cancer. And so it is all a matter of seeing the differences over and over to recognize that there are changes in the morphology that could lead to a diagnosis. So part of my work, an important part, the majority of my work is related to understanding cancers as they develop in the setting of HIV infection. And so we partner with a team in Malawi. And so this is just to demonstrate that you can the use of telepathology, for instance, has expanded the ability and access to care and access to pathology services that are lacking worldwide. So here in Lilongwe, Malawi, the capital city where UNC has a strong commitment and relationship with the university, the slides that are developed in the same way that I demonstrated previously are scanned and digitized in a way that then I can control them from my office and review them both together in a conference, a tumor board like you're all familiar with here, or independently. And that allows for amazing communication and access to services that didn't previously exist. It's also remarkable to us growing up here as a pathologist, growing up here and developing knowledge of molecular testing and advanced testing, how far you could actually get with just histology. So while we often say that's a very old technology, it still gets a lot of answers that I worry that sometimes our patients, even in the States, don't have access to. So there's more than just identifying cancer, invasive cancer, and not. And so these are examples of squamous carcinoma and how histologic evaluation is used to quote unquote grade tumors. And so on the left, you see the most well-differentiated, or what we refer to as well-differentiated, where the infiltrating tumor still resembles very much what the squamous mucosa appears to be like. On the right, you see poorly differentiated, that is, this to us as pathologists looks like wildly neoplastic, dangerously neoplastic carcinoma, but bears no resemblance to the native tissue or the tissue from which it arose. That we refer to as poorly differentiated. And so you can imagine, and then in between a moderately differentiated tumor that you can still appreciate has a look of squamous mucosa, but has a lot of features that become very challenging to distinguish from other types of cancer. These grades are often associated with clinical outcomes. So they may give you information as to how the patient may do. One may look more aggressive, and this is the look that we see, the poorly differentiated, that we say this looks like an aggressive malignancy. And in some cases, until we further evaluate the tissue, we don't even know what cell type has generated that tumor. And in fact, tumors of unknown primary, that is cancers identified, sometimes widely metastatic, we sometimes never, 5% of the time, cannot identify the source of the primary tumor, as it has since differentiated or undifferentiated or de-differentiated in a way that makes it impossible to tell. The same is true in solid tumors, and the same is that which is true in solid tumors is also true in lymphomas and leukemias. And so we have low grade on the left and high grade lesions on the right, where on the left you see cells that we see as being small and monotonous in that they're neoplastic, but not aggressive appearing. Whereas on the right, the difference is that these cells are very large, and we have features that we have come to realize, again, are aggressive or features of malignancy. It is not to teach pathology, but rather to understand that there can be differences appreciated with these. And it is amazing how far just appreciating these differences gets you to the correct diagnosis and the correct treatment. So here's an important distinction. So question 2, colon cancers are common. A series of studies identifies a gene mutation associated with a particularly poor outcome or particularly poor outcomes. In this example, the gene represents which one of the following: a diagnostic marker, a predictive biomarker, a prognostic biomarker, or both a prognostic or predictive biomarker. Great. So this is another one that is that speaks to the importance of the words that we use. So when the answer for this is prognostic biomarker, or C. So the gene may be mutated in a variety of cancers, maybe not. So it's not diagnostic in the sense it doesn't help us make a diagnosis. It helps us tell the clinical teams and the patient that having a mutation in this gene portends a poor prognosis or poor outcome. A predictive biomarker is one that tells us that the tumor will respond to a certain therapy. It predicts a response to therapy. So the difference between a prognostic and predictive biomarker is whether it informs outcome, prognosis, or response to therapy, or predictive. And that becomes very important in our diagnostic world of pathology. So again, this is a prognostic biomarker, informs the patient outcome. Okay, so the evolution of diagnostic testing followed our understanding of cancer biology and the reality that not all tumors that looked similar under the microscope or clinically behaved similarly or had the same outcome. So the cellular and molecular biologic understanding of disease led us to understand those mechanisms, led us to understand features that are diagnostic, prognostic, and hopefully predictive, meaning we can identify features that can be targeted, we can identify tumor features that can be targeted effectively by therapy. And similarly, the technologies that were used to understand cancer biology were then folded into our diagnostic system as well. And so I think it continues to be, particularly at academic hospitals, right, where it's a very reciprocal relationship between the clinical care and the research, and it always goes back and forth. Over time, we saw that developing very much in the diagnostics world, and I'll explain that in the context of B-cell lymphomas. So we understood the maturation of B cells long before we were able to clarify the specific individual disease, the lymphoma subtypes. And so on the right, we'll start here on the right. On the right, you have a pathway of the development of normal B cells. And so you don't have to even think too closely about this. What you have to see is that they start in the bone marrow, these precursor cells developing from hematopoietic stem cells, in this case, a B cell. The B cell does its work as an immune cell, develops in a germinal center or the spleen, and then if it survives, it develops antibodies that protect you from infection, that protects you from other cancers, etc. We also learned that as the cells develop, and this is true of any tissue, they change the surface, not only their appearance sometimes, but the surface markers, the proteins that they express on their surface to function biologically at a given stage. And so this image or figure on the left demonstrates a number of markers, none of which are important specifically on the left, and then stages of B cell maturation on the top, or the x-axis. And as you can see by these shaded bars, is that as cells develop from early cells to late B cells or plasma cells, they express different markers at different times of their development. And so essentially, this CD34, let's say, only stains very early in B cell development, whereas CD20 stains much later, and CD138 stains only at the latest stages. And so knowing that the proteins and the surface markers on these cells change over time, we can use that to both understand and classify diseases, cancers. And so all of these little black boxes that you see here are different cancers associated with different stages of B cell maturation. And because they're essentially associated with a different biological state of that cell, classification systems have arisen that allow us to classify often based on the cell of origin of that tumor, meaning the not only the tissue type, but the state of differentiation of that neoplastic of that particular cell. And so wouldn't it be cool if we could figure out some way to identify what the patterns of expression of these proteins are over the development of a cell's life, essentially? And so the methods that we use frequently are immunohistochemistry, and in the context of hematologic malignancy, also something called flow cytometry. In immunohistochemistry, we look for a marker using an antibody as a probe. And so that antibody, that's where the immuno part of that comes from. If we are interested in expression of a certain marker, we use an antibody that targets that particular marker. And then through another series of reactions with an antibody and other chemistry, we're able to visualize a difference under a microscope that could then tell us that a cell does or doesn't express a certain marker. With flow cytometry, you take fresh cells, you run them through this fluid stream, they are marked with antibodies in the same idea kind of way, and then you can identify what cells express what markers. So essentially, immunophenotyping allows you to identify the stage of development of different cells. And I'll give you an example of flow, for instance, and there will be many of immunohistochemistry in a minute. So we use panels of markers to identify B-cell lymphomas. As B cells normally mature, they express a light chain on their surface with their antibody, either kappa or lambda light chain. So in a benign sample, there will be B cells that some expressing kappa and some expressing lambda light chain based on their just a normal population of immune cells in the background. These are two plots from flow cytometry of a patient with lymphoma. CD19 that you see here on the y-axis stains B cells. And so everything that's high up on the y-axis, this blue population, is a B cell expressing CD19. This particular plot demonstrates 19 versus expression of kappa light chain, and this one demonstrates 19 versus expression of lambda light chain. And in this patient, all of the cells that are 19 positive express only kappa, and none of them express lambda, which is what happens when you have a clonal overtake by one cell that has expanded from by one neoplastic B cell. And so when we identify clonal B cells by flow cytometry, for instance, to identify lymphoma, this is the pattern that we look for. It's not that simple, right? Because there are probably 20 other markers that we're using in combination to further refine the classification of that tumor. But even from this one field, or from this one set of graphs, we can identify that there is a monoclonal population of B cells, which typically implies that there is lymphoma involved. Immunohistochemistry allows us to do the same thing visually. And so here you have follicular hyperplasia, a reactive lymph node that we've all had. So tonsils that are reactive when we're sick or have a cold or look like this under the microscope. And on the right, follicular lymphoma. And you don't need to know any of these markers either, but just identify that normal and abnormal look very different for us using this series of immunohistochemical markers. And so our IHC allows us to tell what is normal or confirm what our suspicion of what is normal or abnormal, and then issue an appropriate diagnosis for the patient. The problem with much of this is that when you think about the spectrum of maturation of B cells, for instance, if a cancer is arising from a state of development, it's unlikely that it's just all of a sudden one, and then all of a sudden the other type of tumor, and all of a sudden the third. So the diagnoses are very infrequently clear-cut. And so while we try to bin them in manners that are in clinically meaningful bins, right? Clinically meaningful diagnoses, it's not as straightforward as just it is positive or negative. And if it were, then, which would be awesome, then we would probably use some sort of imaging analysis to tell us immediately what the diagnosis was, which is not, even now, still possible. So for instance, the further expanding on the fact that the staining is rarely kind of binary, negative or positive, that could happen for a number of reasons. Some could be biologic, meaning there's just different protein expression in different parts of the tumor and different cell types. And some could be technical. Our capacity to identify a certain protein may be better for one than for another. And even in the setting of a prognostic biomarker, that is c-Myc, this protein expression in the context of diffuse large B-cell lymphoma, the staining is rarely easy to evaluate. And so in this case, 40% is considered positive by the literature. And when you look at this one image where the brown stain is positive and the blue stain is the negative cells, it's really hard to tell what is meaningfully positive versus what is negative, right? So it's just, this is the subjectivity of evaluating histology that often comes across as being very concrete and specific. So the development of other testing modalities have allowed us to further understand, again, the biology and classify tumors further. And so the testing that I'm confident you will go over, we have an amazing group of molecular scientists and molecular pathologists here at UNC. But these are the testing, this is the type of testing that's now used in the US at UNC for the classification of many malignancies. When one orders a karyotype, that is routine cytogenetics, one evaluates the whole genome, and I'll show you an example in a minute. You can get more specific using fluorescence in situ hybridization, maybe even sometimes more sensitive. And then we've moved on to sequencing technologies, and all of you have heard of next generation sequencing panels that allow us to interrogate many genes at a time. Briefly, karyotype is when live cells are cultured, arrested in metaphase, that is when the chromosomes look that beautiful shape that they look in when we learn in high school and college, and stained in a way that allow us to then identify which chromosome is which. The advantage of a karyotype is that it allows you to see an unbiased look at the entire genome. So you can see big genomic changes you can see in the genome. The disadvantage is that it's poor resolution to some degree, meaning cancers are all a genetic disease in some way, but karyotypes don't pick up mutations or aberrations in all types of cancers, right? So you could have a normal karyotype, but a tumor is still very much at play and in the diagnosis. This happens often in a diagnosis of acute myeloid leukemias that many of you deal with. This is what happens when the chromosomes are arrested in metaphase and stained. And then again, we have an amazing cytogenetics laboratory at UNC, truly an exceptional cytogenetics laboratory at UNC. And so technologists are capable of now, they can do it on a computer, but they used to cut out the different chromosomes and align them in what you've become used to seeing as a chromosomal complement or a map of chromosomes. And from this pattern, just the pattern of the more condensed and less condensed type of DNA and staining pattern, we can identify large losses or gains of genes. And this takes a few days at a minimum to do. FISH, or fluorescence in situ hybridization, is also targeting mutations or aberrations in the DNA, but we're specifically using probes towards sequences that we're interested in. So for instance, if we knew that there was a certain cancer that had a certain type of genetic sequence, a certain type of DNA sequence, and it's listed here, we would use a fluorescent probe to stain or anneal with the DNA sequence of interest. And this fluorescent probe can be visualized in this interphase FISH as this green dots all over, right? So in this particular example, there are far too many copies of a gene, suggesting one of several genetic aberrations, depending on the probe that we use. But this is fluorescence in situ hybridization as the next step. The advantage that increases resolution compared to the karyotype, but we or you have to define what it is that we're interested in targeting, as it does not just like it doesn't, we can't do FISH for everything, whereas the karyotype gives you a full complement. And finally, DNA sequencing that has existed now for, again, many decades has been revolutionized over the past 15 years. So classic sequencing called Sanger sequencing essentially allowed us to identify the sequences of small fragments of amplified DNA. And so for this will be in the slide deck and in the handout, but briefly, you can identify by reading essentially from bottom to top or top to bottom, depends, the order of the different nucleotides to get a sequence of a small fragment of DNA. This technology was used to sequence the human genome, and it took a really long time. Now we've moved on to next generation sequence or next generation sequencing that you've heard of in panels, and that is a slightly more complicated, very elegant methods of amplifying numerous targets in the same reaction. And so when somebody has a disease like myelodysplastic syndrome or AML, and we're interested in identifying the prognostic, sometimes predictive biomarkers, we could look at a panel of genes and say that they are or are not mutated, that can drive both diagnosis and therapy. So again, the evolution of testing has followed from morphology or the light microscope all the way to these molecular studies that are essentially driving the classification. And in fact, there are so many different tumors that are now classified and subclassified with molecular techniques that it's almost unrealistic to have the same diagnoses issued at a hospital or center that is not equipped to do a lot of this type of testing. So why is a uniform diagnosis, or why is the uniform classification system important? So ultimately, we wish to improve the care for patients. And the best way to improve the care of patients is to identify them, treat them effectively based on the diagnosis that they have. But those diagnoses, the treatment is selected for those diagnoses based on often large clinical trials that demand appropriately that patients are categorized effectively in the first place. And so we not only do we classify for the patient, for the individual patient that we're dealing with, and in the moment that is the most important task, but we classify effectively for clinical trials, and more importantly, for public health and public policy, because all of these diagnoses ultimately are registered in cancer, are ultimately included in cancer registries, and the cancer registries define where money is spent, what focus is placed on different tumor types. So over the past 20 years, the World Health Organization and the International Agency for Research on Cancer, essentially like a part of the WHO, the World Health Organization classification, brings together experts that define that every 4 to 5 years, redefine or reshape the classification based on new knowledge. And so for every different organ system, for instance, you can go to the World Health Organization classification system and see what the current classification of those tumors is. And that should be true for tumors that diagnosed in North Carolina, and they should be true tumors diagnosed in Spain. I mean, this is meant to uniformly categorize tumors. Parenthetically, these World Health Organization classification schemes are largely based on the countries that have access and the wealth to do the research for these cancers. So while cancer is an enormous burden in third world countries, we don't even know the distribution of different cancer types or their genetics, as there's often less access to those technologies and to the data coming out of those technologies that could be used for meaningful classification. When we think about it closer to home, we don't even have uniform representation of our population in the US in these registries, in these systems. As we well know, a whole separate talk, that there are a lot of disparities in what gets included and how patients are treated, but that again, a whole separate talk. But briefly, you can go to this website. Here's the link at the bottom. And under different tumor types, here skin tumors, eye tumors, hematolymphoid tumors, each one of those has a classification system that we expect as a community of pathologists, as a community of oncologists, to report similarly no matter where you are in the country. And so that is what we follow. It's not kind of like a passed down by word of mouth. There are classification systems that we follow. The role of molecular testing has been significant. And if you see here, this is just a classification of myeloid cancers from the World Health Organization classification of heme malignancies. And of all of the different myeloid cancers, those in red are the ones that are that demand molecular testing for classification. So again, in the States at UNC, we're privileged to have the laboratories that we have and access to care that we should have. We can make these diagnoses, but you can imagine that a lot of this is very challenging to get access to globally. Oftentimes, many of you have probably experienced the reality of getting referral cases or patients being referred to UNC or a central hospital for re-diagnosis or for treatment. And when patients are referred to UNC for treatment, it is by rule that we need to review their pathology diagnosis in order to know that what we're treating or what we're hoping to treat on the clinical side is what the patient has, right? We need to confirm diagnosis from the outside. This has a lot of challenges to it, right? Because sometimes patients decide that they're coming for a consult because we want to be efficient. We review the case, and then they decide not to come for referral or consult. And then they're left with like billing issues and cases being reviewed and the patient's not being seen. And this is a very complex phenomenon, or a very complex system. But the idea that patients are all reviewed here in order to be treated here. And same is true for Duke, and same is true for Wake, and same is true for any other cancer center, certainly one that is NCI designated. Discordances are not uncommon. And so if we look at this one paper where the discordances are modest, there was within the past, in 2008, this paper came out, that they reviewed lymphoma diagnoses of 731 cases of patients with the 5 most common lymphoma subtypes. And 43 of that 731, or 6%, were discordant from primary review from wherever the patients were coming to where the patient had come to an NCCN, in this case, cancer center for treatment. So 5% is still 1 of 20, right? In many cases, and importantly, 35 of 43 that they concluded may have had a change in their treatment. Importantly, in many tumor types, particularly those that are really difficult, many solid tumors, brain tumors, for instance, discordance is greater than 25%, so greater than a quarter of tumors get a new diagnosis or an updated diagnosis from a peripheral site centrally. So it speaks to the importance of re-review of that tissue, right? To central re-review of that tissue before treatment. Depending on the depending on the tumor type, discordance can be high. All right, so last question. A study of human pancreatic tumors implanted into mice identifies a new prognostic biomarkers by IHC, by immunohistochemistry. These findings are reported in a high-impact journal, and the antibody used for IHC for testing is available from the research lab. Can you use this test for clinical decision-making? Yes, immediately. Yes, but only after the antibody is commercially available. No, there's insufficient evidence, and no, it must be FDA approved. Yeah, this is great. So the answer is no. And you would be surprised at how many times this comes up, right? We're all very interested in the newest. But there are a bunch of reasons, largely because that antibody hasn't yet been validated. It's a difficult question. So C is the actual correct answer, although D probably has an accuracy in the sense that it doesn't necessarily need to, while the antibody doesn't necessarily need FDA approval, there are regulatory considerations. So know that the antibody can't be used, and it is largely because it hasn't been clinically validated in large studies and locally. And this gets to the last part, which is the College of American Pathologists and Synoptic reporting that many of you deal with, both on the clinical trial side as well as others. So remember that the goal is to identify and report just the most important information for patients, the most important information for clinical teams, so that patients can be best treated. The College of American Pathologists, which I'll talk about a little bit more in a second, is a huge pathology organization, and part of it, the Council of Scientific Affairs, essentially develops surveys that they send to all pathology labs yearly. So, for instance, none of the words are important. The numbers and the complexity of it is. Here are different surveys listed on the left, different hematologic surveys, and different years and quarters within those years. And these are the numbers of labs that are participating in these surveys. So in order for our lab to get accredited, and this is true for testing a lab analyte like hemoglobin hematocrit, as well as for microscopy, there is a system in place that we do essentially testing, proficiency testing, to make sure that we're reporting the correct things, right? So the College of American Pathologists has a long-standing history of being kind of the major source of this proficiency testing material. Probably in the 90s, there was certainly since the 90s, there's been a lot of work demonstrating that there's too much variation, or highlighting the reality that there's too much variation in how cancer diagnoses are reported. So the College of American Pathologists has essentially maintained what they refer to as the synoptic reports for different cancer types. So a synoptic report is essentially a tumor-specific checklist that allows the pathologist to identify specific fields which can be entered for a patient tumor type. Because these are discrete data elements, this is more on the informatics side, and may be interesting to some of you that are registering or inputting patient information. For different tumor types, the discrete data elements are often related to those that are necessary for clinical trial reporting. And so this, for instance, is examination of specimens from patients with squamous cell carcinoma of the head and neck. And while I show you only one page to tell you what exactly is some of the features, this goes on for many pages. And again, as we are demanding more information, it becomes harder to include all of this information in a synoptic report, because that becomes more complicated than just issuing a simple diagnosis of squamous cell carcinoma. But nonetheless, this is the complexity. This is the attempt to unify the classification using synoptic reporting. Checklists improve completeness and improve accuracy to a point, unless they get too complex. And then for those who read them, whether it's you or us as pathologists reading other pathology reports, there is a body of literature cited in this paper here that I have cited at the bottom, that often discusses the role and value of consistent formatting, text versus columned information, and single line versus multiple line data, right? So that's very specific data elements and presentation of those data elements. So it's not just getting the data, it's reporting it effectively to the clinical team, to the clinical trials office, et cetera. And finally, and very briefly, tissue sampling for diagnosis. Specimen adequacy is a major challenge in clinical practice, and limited sampling can lead to missed or delayed diagnoses and insufficient tissue for study for enrollment for correlative science. In response to the trend, other diagnostic methods like liquid biopsies are being developed, but we still heavily rely on high quality tissue for an effective diagnosis. And I'll give you just one example, and I promise I'm almost done. So this is a bone marrow biopsy, and you see here that this is the bone, this dark pink, and this patient, the space where we typically see marrow has almost nothing, no cells in it. This is all fat, and this is very worrisome. And we would think of things like aplastic anemia, drug toxin effect, these other diagnoses, graft-versus-host disease. In reality, that is just part of the bone that doesn't have cells in it normally, the subcortical bone. And here there's the marrow that we can evaluate. However, this biopsy alone is often the size of the biopsies that we get to interpret, and can lead to missed or delayed diagnosis, certainly a misinterpretation of what the patient's hematopoietic capacity is. The same is true for fine needle aspirates, which can be very simple and high yield to triage a patient, but can be remarkably ineffective at classification and require subsequent biopsies. So as an example, this is a FNA, a fine needle aspirate of a 5 centimeter axillary lymph node that shows primarily blood with a little bit of neutrophils. The patient came back to then have these large cells on a repeat fine needle aspirate. And even though we can see by flow cytometry and morphology that this is lymphoma, a tissue biopsy was ultimately necessary to classify that lymphoma. So 3 procedures to get this patient to final diagnosis, where one would argue that a 5 centimeter axillary lymph node may not need that long of a delay. So in conclusion, effective cancer care requires accurate pathologic diagnosis. Testing methods have evolved that reflect our understanding of cancer biology, and those have improved reporting for prognostic and predictive biomarkers. While new technologies are being developed to do more with less, an adequate tissue biopsy is still necessary. And synoptic reporting allows for discrete data elements to be provided for consistency in data collection. So with that, I thank you, and any questions or comments can be typed in or asked.
Dr. Fedoriw, thank you so much. This has been fascinating. We do have the questions open now. Let me start with one. I know early in the presentation you had mentioned pattern recognition, and can you talk a little more about the interplay between pattern recognition and the pathologist actually viewing the specimens and what that interplay looks like?
Yeah, so that's a great question. So what we have learned is that we spend so much of our time, just like the clinical teams do, in observing patients that are healthy and sick and coming in for routine checks and coming in for cancer diagnoses, that the patterns of what we see are profoundly different under the microscope, just like they are clinically. So we're so used to seeing different normal tissue types that then when we see something abnormal, we can typically start binning it into groups of like, this is cancer or not cancer, and then what type of cancer that may be. We take a lot of, because we have a great relationship with our clinical team, certainly in our heme group, and I would say that our ability to communicate with the team allows us to give a more accurate diagnosis. The oncologists themselves, the physician extenders, the nurse practitioners, the physician assistants, they know, they've narrowed down the diagnosis of what cancer the patient has even before we get the biopsy. They already have an idea of what it's going to be. And so it is truly, while we look at the tissue, it is a team effort of making that diagnosis for the patient.
Great. Thank you so much. And let me bring up, I know we've got at least one question from our audience. It looks like we already have a couple. So let me put up that first one. I've heard about pathology wet reads during after surgery. Is this accurate or used?
Yeah, so wet reads or frozen are what I think frozen sections. That is, like during surgery, one can look, or you can do it in FNA as well. One can look more quickly at a piece of tissue. The challenge is that there is almost an expected overturn rate of some of those diagnoses, largely because it gets prepared in a way that doesn't preserve the tissue as well as the histology method that I demonstrated previously. So it is very good for certain things, sometimes identifying, again, tumor along a margin, or whether tissue has been sampled effectively for further investigation. But there is almost an expectation that there is going to be some discrepancy, some low level discrepancies between the two. So both. It is accurate, used, and imperfect.
Great. Thank you so much. And we're getting several questions and some very complimentary remarks as well. Next one, if you had to explain in lay terms what next generation sequencing is, what would you say?
So next generation, as opposed to sequencing one particular gene of interest, next generation sequencing allows us to sequence a bunch of different targets all at the same time. So if we knew that a person has a certain cancer type, and there are 20 different genes, 100 different genes, 500 different genes that may provide information for that patient, instead of sequencing each one of those individually, we can sequence them in one tube off one sample and identify the different aberrations for a given for any gene. So it's essentially allowing you to look at a panel of different genes at the same time.
Great. Thank you so much. Another one, can you speak to the integration of histologic results with cytogenic and molecular genetic results that may take weeks to become available? Is the diagnosis continually refined by the pathologist as additional results become available? Interesting.
That's a great question. So that's very challenging because that could be that's the reality. Some of these tests, in fact, our cytogenetics lab that's very fast at issuing preliminary diagnoses, at least very fast nationally. Sometimes you're waiting to get the final diagnosis. It does take a few weeks to get some of the diagnoses for this testing back, especially if any of it is sent out of UNC. If the diagnosis is the challenge for us is that diagnosis is often issued first, and then we say there could be correlation. If there is if oftentimes EPIC allows us to integrate the information that comes back to us from molecular testing, and if that changes substantively changes the diagnosis, then that a diagnosis is amended or addended to update the classification.
Great. Thank you so much. Another one, how many labs have to clinically validate a prognostic biomarker before it starts to be used for diagnosis and clinical decision making?
Right. Yeah. So this is a clinical validation. There are clinical validations and analytical validations, and both are complex. So generally speaking, the clinical validation requires not necessarily that a certain number of labs do them, but it's in a community accepted that is something we can test for. Then we need to validate it in our own hands, analytically validate that test, and then identify whether and then depending on kind of the testing features of that specific assay or specific test, then we can say that this is sufficient or not. It's not as easy as like a certain number of labs for a given test. It's very holistic and depends on a bunch of features.
Thank you so much. And we're going to take this final question. Boy, we could use another hour with all the questions coming in. But are we seeing surgical procedures and techniques change to keep up with the need for better specimen collection?
Oh gosh, so I have a strong feeling about this. So generally speaking, in the U.S., we try to do that, which is minimally invasive, and that's great. That's wonderful. Except it does limit the amount of tissue that one has available for both study for the patient's diagnosis and study for research studies, for clinical trials, et cetera. It has been, I would say that we've had great communication with our surgical teams at UNC. So overall, the quality of biopsies that we see at UNC, let's say in heme, the world of which I could speak, is they're quite big. We get good excisions. Other places are having a harder and harder time managing the sample size, which we've been fortunate to be safe from, I guess. Yeah.
Great. Thank you. I'm just going to put up a few of the nice comments that were shared.
Yeah, and again, I'm available. I'm in your world, so I could answer questions if need be in the future.
Great. Well, Dr. Fedoriw, thank you so much. This has been, again, fascinating. I think we've all learned a lot. I want to thank the entire team here at UNC Lineberger Cancer Network, and that's John Powell and Veni Obure and Oliver Marth and Patrick Muscarella and Andrew Dodson and Nadja Brown for all of their effort with each and every one of these presentations. We want to